Safe practice requires abandoning memorized drug lists. We must look beneath the symptoms and identify the specific cellular errors causing the breakdown. Treatments for joint pain, autoimmune disorders, and cancer overlap heavily. They share drugs because they target the exact same mechanisms of cellular disruption. Nurses manage three primary domains of systemic failure: mechanical degradation, immune misfiring, and uncontrolled cellular proliferation. To master the vast pharmacological arsenal, from NSAIDs to alkylating agents, you map the drug directly to the microscopic error it corrects. We organize these diseases and treatments into a three-column matrix: mechanical, autoimmune, and oncology. The left column represents mechanical failure, a localized wear and tear requiring localized management. The middle and right columns represent systemic crises. Here, the entire network is compromised, requiring systemic, toxic interventions. This matrix serves as a diagnostic tool. It predicts therapeutic efficacy and the specific physiological crises these treatments will induce. Osteoarthritis, or OA, sits firmly in the mechanical column. It is a localized, non-inflammatory destruction of cartilage. Looking at this anatomical comparison between a healthy joint and an osteoarthritic joint, the structural failure is obvious. Notice the labels indicating a bone spur and severely thinned cartilage on the right. The cushioning between the bones is gone. This structural damage dictates the clinical presentation. Patients experience pain that worsens with physical activity and a grinding sound called crepitus, caused by direct bone-on-bone friction. Unlike inflammatory conditions, OA lacks systemic lab markers. Its physical markers are structural, like Heberden's nodes at the distal finger joints and Bouchard's nodes at the proximal joints. Because the disease is local, the pharmacological strategy is local. Interventions progress from oral acetaminophen and topical agents like capsaicin and diclofenac, escalating only to intra-articular corticosteroid injections. Treating OA with systemic opioids like tramadol is strictly reserved for severe, refractory cases. The root cause remains a localized mechanical failure, so exposing the entire body to systemic side effects is a last resort. Moving to the autoimmune column, we encounter rheumatoid arthritis and systemic lupus erythematosus. In these conditions, the immune system misidentifies the patient's own healthy tissues as foreign threats and relentlessly attacks them. This illustration of a patient's hands highlights the presentation of rheumatoid arthritis. The red areas indicate severe inflammatory symmetrical joint swelling, specifically targeting the proximal and metacarpophalangeal joints. RA is systemic. It presents with severe morning stiffness lasting over 30 minutes, profound fatigue, and noticeably spares the distal joints near the fingertips. Systemic lupus erythematosus, or SLE, expands this immune failure across the entire body. Patients often present with a classic butterfly-shaped facial rash, but the disease lethally targets major organ systems, causing lupus nephritis in the kidneys, pericarditis in the heart, and pneumonitis in the lungs. The initial pharmacological response for both RA and SLE during acute flares relies on systemic corticosteroids like methylprednisolone and NSAIDs. These agents violently interrupt the inflammatory cascade. While steroids quickly suppress acute flares, they do not halt long-term disease progression. Managing these conditions requires transitioning to agents that rewrite the immune system's behavior entirely. Disease-modifying anti-rheumatic drugs, or DMARDs, serve as the foundational long-term immunosuppressants. The primary agents are methotrexate, hexachloroquine, and sulfasalazine. These drugs carry specific severe toxicities. Methotrexate causes hepatotoxicity and requires strict folate supplementation. Hydroxychloroquine mandates regular eye exams due to the risk of irreversible retinal damage. Advanced biologics, or DMARD2 agents, target highly specific immune pathways. These include TNF inhibitors like etanercept for RA and SLE-specific monoclonal antibodies like belimumab. A universal nursing priority applies to all DMARDs: diligent monitoring of the complete blood count and liver function tests. These drugs induce myelosuppression, suppressing bone marrow function. The clinical trade-off is clear. Preventing the immune system from destroying the patient's joints or kidneys requires the deliberate creation of an immunocompromised state, introducing entirely new risks of severe infection. In the oncology column, the patient's own cells ignore the signals for apoptosis and divide uncontrollably. This diagram illustrates metastasis. You can trace the pathways showing the primary cancer migrating through the lymphatic and vascular systems to form secondary tumors in the lung and liver. A localized cellular error quickly becomes a multi-organ system failure. This cellular takeover generates severe systemic manifestations, including unexplained weight loss, profound fatigue, and the development of palpable masses throughout the body. We measure this spread using the TNM staging system, which quantifies the tumor size, node involvement, and the extent of metastases. Because metastatic cancer is inherently systemic and fast-growing, a pharmacological cure must be equally aggressive. This sets the stage for chemotherapy. The anti-neoplastic arsenal attacks specific phases of cellular division. S-phase disruptors block DNA synthesis. These anti-metabolites include folic acid analogs like methotrexate and pyrimidine analogs like cytarabine. M-phase disruptors physically prevent cell division. These mitotic inhibitors include vinca alkaloids like vincristine and taxanes like paclitaxel. Other agents alter DNA regardless of the cell cycle phase. Alkylating agents like cyclophosphamide and platinum compounds like cisplatin directly scramble the cell's genetic code. For sex hormone-dependent cancers, targeted modulators like tamoxifen and luprolide are used to starve tumors of their specific growth catalysts. These drugs destroy fast-dividing cells indiscriminately. While they kill the cancer, they annihilate the patient's bone marrow in the process. This collateral damage mandates a hematopoietic rescue strategy. We use erythropoietic growth factors like epoetin alpha to rebuild red blood cells, leukopoietic factors like filgrastim for white blood cells, and thrombopoietic factors like oprelvecin for platelets. Looking back at our matrix, the overlap between rheumatology and oncology becomes clear. Efficacy in both fields relies entirely on cytotoxicity. Methotrexate treats both severe rheumatoid arthritis and cancer because its underlying mechanism, stopping rapid cellular activity, is identical in both contexts. The severe physiological cost of this shared mechanism is the rapid depletion of the body's natural defense systems. The definitive nursing priorities for these patients require relentless monitoring. Neutropenia creates an immense infection risk, while thrombocytopenia creates a severe bleeding risk. In both severe autoimmune and oncologic care, the clinical risk profile shifts from the primary disease itself to the toxicity of the medication. The ultimate medical emergency occurs when these aggressive therapies are highly successful. This causes tumor lysis syndrome, or TLS. In TLS, massive numbers of malignant cells die simultaneously, rupturing and dumping their contents into the bloodstream. This immediately spikes potassium, phosphate, and uric acid while dropping calcium. This electrolyte dump causes lethal arrhythmias from hyperkalemia and acute renal failure from uric acid crystallization. Immediate stabilization requires aggressive IV hydration to flush the kidneys, the administration of allopurinol to lower uric acid levels, and continuous cardiac monitoring. Other oncologic emergencies, like superior vena cava syndrome or spinal cord compression, similarly require immediate mechanical or physiological stabilization over standard disease management. Clinical judgment involves tracing a drug's effect to the cellular level to predict exactly how it will destabilize the patient's internal balance.